Alright guys, we're going to do Parkinson's disease, and Parkinson's disease is on page 432 in your book. Okay, so what's going on with Parkinson? Again, it's a progressive, degenerative, chronic neurological disorder. We really don't know what causes it. What do we know? We know that approximately 20% of people with the disease have a family history. We know that the disease itself interrupts a person's life and is characterized by slow movement, which is bradykinesia, increased muscle tone, which is rigidity, tremors at rest, and gait disturbances. Okay? Why does this happen? We know that the disease process causes there to be a decrease in the number of neurons that produce dopamine. Okay, so there's a decrease in the number of neurons that produce dopamine. And so then when dopamine is released, there's not enough of it. And then the balance between dopamine and acetylcholine is off kilter. And so remember that acetylcholine is the excitatory neurotransmitter, and it being the excitatory then causes the excess muscle rigidity and the excess neuron firing because there's not enough dopamine to offset it. And so the patient essentially loses control of voluntary motion because of the lack of dopamine and too much acetylcholine circulating. Okay, this is a picture of an individual that is experiencing Parkinson's disease. Often the disease onset is slow. Your book actually says that people usually don't even get signs and symptoms of Parkinson's until there's 80% destruction of the neurons that produce dopamine. One of the first signs and symptoms is tremor. It usually can go unnoticed, but one thing that patients that first have Parkinson's do is called pill rolling. And pill rolling is as if they have some small type of object, maybe a coin, and they have it, between their thumb and forefinger, and they're rolling it. But this is not a controlled movement. They cannot control it. And then tremors will move on and can be experienced like in the face, and in the diaphragm, the head. Next often is rigidity of the muscles. So they have increased resistance to motion. And specifically, Parkinson type rigidity is called cogwheel rigidity, which has a jerky quality to it. This rigidity makes it difficult to move, difficult to walk. And then next in the triad is what we call bradykinesia. And it is secondary to the alterations of not having enough dopamine. And so they have lots of different things that go on. They blink their eyes often, swing their arms while they walk. They have lots of salivation. They have different facial expressions, or even sometimes called a lack of facial expression. They have postural instability. And these are just a few of the muscle type issues that they have. But also know that what goes along with Parkinson's a lot of times is emotional issues, including depression and anxiety and fatigue, sleep disturbances. And a lot of times people who have Parkinson's also develop dementia and can develop hallucinations and psychosis. There is, once again, no specific test that says, hey, you have Parkinson's. They have to have 2 of the 3 classic symptoms, the tremors, rigidity, bradykinesia present, rule out other disease processes, and then we see that they have an actual positive response to the drugs. And that's how we diagnose someone with Parkinson's. We'll talk about meds on the next slide. There are several different types of surgical intervention. One that's very popular is deep brain stimulation, and your book talks about deep brain stimulation, and there's an actual picture on page 1436. And so this is where the patient has an actual electrode placed in their brain. It's connected to like a pacemaker generator box, and then this device can actually be controlled, and it can be removed if needed, and it is programmed to deliver a specific current to a targeted area of the brain to help improve movement. Other things that have been done in this area are ablative therapy, where they actually go in and kill a group of cells. And also, the other thing that they're working on is the actual transplantation of fetal neural tissue into the brain of people with Parkinson's, and hoping that it will regenerate or grow as dopamine producing cells. These guys need ongoing physical therapy, occupational therapy, and speech therapy as their disease progresses. There are several classes of drugs that can be used to treat Parkinson's. These drugs actually start on page 1434 and go into 35. And so by far the most common is carbidopa-levodopa, which is Sinemet. So that is the most popular drug. It just helps there to be more dopamine available by allowing the levodopa to cross the blood-brain barrier. And so it allows more dopamine to be available to help offset the imbalance between the dopamine and acetylcholine. Physicians believe that this can lead to dyskinesia, so we need to monitor for dyskinesias, instruct the patient to report any new onsets of uncontrolled movements, and they also can experience what we call on again, off again periods when the med works and then stops working. And physicians also believe that these drugs lose their effectiveness over time, and therefore sometimes they will initiate with another class of drugs called the dopamine receptor agonists. The specific one that I gave for you guys as an example is the bromocriptine, and they sometimes will start therapy with these. And these, you just have to make sure that the patient understands it can make them feel dizzy or faint due to orthostatic hypotension, so make sure they change positions slowly, and that if they develop headaches, they need to let the physician know. Sometimes anticholinergics are used, and the anticholinergics are used just to decrease the activity of the acetylcholine. So this should produce a better balance between the different receptor sites. The COMT inhibitors, they actually block an enzyme that break down the levodopa, therefore making more levodopa available. This particular class of drug is generally used in combination with Sinemet. And then the monoamine oxidase inhibitors, these guys often are used in combination too, and they just make more of the dopamine available by stopping the breakdown of the dopamine. When taking care of someone who has Parkinson's, you need to realize that they're going to obviously have impaired physical mobility. This is due to the muscle rigidity and the bradykinesia and the akinesia. And so we just need to make sure that we have physical therapy consults, that we teach them to do range of motion in the beginning. We need to make sure that we offer them assistive devices to help them throughout the day, encourage them to get raised toilet seats, put handrails in the bathroom, get rid of rugs, extra furniture, make sure that there's adequate lighting. If you look on page 1437, it actually talks to you about how we need to teach patients with Parkinson's and some safety alerts, and that they tend to freeze while walking. So we encourage them to consciously think about stepping over an imaginary or real lines on the floor, drop rice kernels and step over them, rock from side to side, lift their toes when stepping, and take one step backward and 2 steps forward. And this helps with their mobility. Impaired verbal communication could be an issue, so we're going to have to encourage them to attend speech therapy and pick alternative ways to communicate. Imbalanced nutrition, these guys will suffer obviously from dysphagia and be at risk for aspiration. So we need to make sure that we cut their food into small bite size. We need to make sure that we're weighing them. It's better if they eat 6 small meals a day. A lot of times it can be less exhausting and less frustrating. We should note the fact that levodopa can be impaired by protein ingestion, and therefore patients are advised to limit their intake of protein to the evening meal and to kind of spread it out evenly over the day. And these guys obviously are going to be at risk for constipation, so in their diet we need to make sure that there is fiber and plenty of fluids.